We're going to focus on the fetal thyroid. Kind of been going through some organ systems of the fetus, and I thought we would focus on thyroid and pregnancy. We'll talk briefly about maternal changes and how that impacts fetal development. So the fetal thyroid gland, oh yeah, here I am. Feels like, get the camera away from me. The fetal thyroid gland is the first endocrine gland to develop. It originates in the first and second pharyngeal pouches, which I had a tick when I had PTSD hearing about pharyngeal pouches, but that's endoderm origin, and it's near the base of the fetal tongue. And at 3 weeks, these endodermal cells of the early pharynx proliferate to create the thyroid diverticulum. This diverticulum then starts to migrate caudally into the neck at 5 weeks, and it remains attached to the tongue via the thyroglossal duct. And on its little journey to the neck, the thyroid goes from hollow to solid and forms its follicular elements. At the end of 5 weeks, there's division of the right and left lobes of the thyroid, and there starts to be differentiation of the parafollicular C cells, which are needed for calcium hemostasis. At 7 weeks, the thyroid arrives at its final destination in the anterior neck, anterior to the hyoid bone. And at 10 weeks, the thyroglossal duct degenerates, leaving behind the foramen cecum, which is that little pit at the very back of your tongue. However, the key thing here is that the fetal thyroid isn't functional until the second trimester, and that's really, really important for development. So it's in the right location, it's formed, but it is not making thyroid hormone yet. So thyroid hormone, specifically T4, is essential for fetal neurogenesis. And the hypothalamic pituitary thyroid axis undergoes maturation in utero that happens after the thyroid arrives in its right location. So at 8 weeks, the fetal hypothalamus starts to make thyrotropin releasing hormone, known as TRH, and that stimulates the fetal pituitary gland to secrete TSH, or thyrotropin stimulating hormone. And at 18 to 10 weeks, the fetal thyroid gland is functionally mature and TH levels finally begin to rise. But it's not until 30 weeks when fetal T3 and T4 levels really begin to take off. So you can see here, especially in the first trimester, the fetus is not making its own thyroid hormone, and it is solely dependent on maternal thyroid hormone for fetal neurogenesis to happen in that first trimester. The hypothalamic pituitary thyroid axis does not become fully functional or fully mature until 1 to 2 months after birth. So this is kind of a graphical summation of what we've talked about, but the key part here is that free T4 levels and T3 levels, the functioning thyroid hormone, does not begin to really take off until well into the second trimester. So as I touched on, maternal thyroid status is really essential, especially in the first trimester, because the fetus is only getting its thyroid hormone, especially during the first trimester, from mom. So mom's T4 crosses the placenta. So in the first trimester, what mom is providing to the baby equals the fetal T4. Mom TH does not cross the placenta, which is a key part of this. So we have to wait till the baby is making its own TSH for then that hormone, or for the thyroid to become functional. As the fetal HPT axis matures, the dependence on mom for thyroid hormone decreases, but it never really officially goes away until after birth. And this is reflected by the fact that at birth, maternal T4 compromises almost 50% of the total T4 measured in the fetal cord blood. So we're going to jump into mom a little bit here, which is that there are some important maternal changes that happen to the thyroid during pregnancy of mothers, which is there's an increase in size up to 30% during the third trimester. This is from an increase in extracellular fluid and also blood volume. Maternal T4 concentrations increase by up to 50% throughout pregnancy. And there's also an increase in thyroxine binding globulin, which is mainly the influence of estrogen. TSH also changes in pregnancy. So we know that TSH decreases in early pregnancy. This is because HCG weakly stimulates the TSH receptors. So you're having an increase of free T4, which then suppresses the TSH releasing hormone, and you have less TSH from the pituitary. So that's the negative feedback that is caused by HCG in early pregnancy. As HCG plateaus, TSH returns to baseline in the third trimester, and then TSH actually increases in the third trimester a little bit, and this is because the placenta, as it grows, it has deiodinase, which catalyzes conversion of T4 to T3, and it also catalyzes conversion of T3 to T2, which is an inactive form. So you're having a little less functioning thyroid hormone, so your TSH will increase. And this is kind of the mom flow chart that you can see. So the little dip in TSH, which is in the green check line, is influenced by the stimulating impact of HSG. And you can see here after 10 weeks, so in the second and third trimester, your total T4 is going up, which is mainly the influence of thyroid hormone binding globulin, but your free T4 goes up slightly and then kind of plateaus. So just to touch briefly on maternal thyroid function tests in pregnancy, and I'm not going to focus a lot on mom here, but it is important to address that we have different normals. So in the late first trimester, your lower end of normal is going to be your lower reference range minus 0.4. And then in your upper normal kind of parameter is going to be the upper of reference range minus 0.5. And we know that TSH decreases in the first trimester, so that reflects that. After the first trimester, you're going to use non-pregnant reference ranges. We usually say like the upper limit of normal of 2.5. Then for total T4 and total T3, which we usually follow free T4, but these gradually increase. And after 16 weeks, your total T4, which you'll see is going to, normal will be the upper reference range plus 50%. However, we follow the free T4. I think I get to that in the next one. Yeah, I get to that in the next part, but just to touch on, we follow free T4 when we're looking for management of hyperthyroidism, and that you want on the higher end of your normal. Iodine is very important for fetal thyroid growth, and the fetus relies entirely on maternal iodine for thyroid hormone production. Your daily iodine need increases in pregnancy, so you need about 150 micrograms when you're not pregnant, and that almost doubles while you're lactating, and 250 in pregnancy.
Iodine is salt.
Yeah, so here you go. So it's like what, we know salt. So in modern developed societies, the way to combat iodine deficiency is they started adding it to salt. So you have iodized table salt, which to Neil's question, 1/4 of a teaspoon is 76 micrograms of iodine. So I feel like I put salt in everything, so I'm rolling in iodine. But my prenatal is 150 micrograms iodine. Other foods like bread, which is enriched, has a lot. Interestingly, like lots of seafoods, I haven't been eating a lot of baked cod this pregnancy, but that has a lot of iodine. yogurt, milk, dairy, things like that. The people that you have to worry about are like vegans who don't like salt, which like, what are you eating then, may get into a little bit of an issue. But you do have supplementation through your prenatals. The other thing I'm going to kind of pivot, the other tests that oftentimes come up when we're talking about thyroid disease is the question of thyroid antibodies. And I want to make a key distinction between two different types of thyroid antibodies. So like someone will come to you and they'll be like, oh, should I test the thyroid antibodies? They were tested. The key difference is the thyrotropin, which is a fancy word for TSH. The TSH receptor antibodies are the key ones that we're looking at. So these are the TSIs, which is the acronym that we'll see, or the TBIs. These cross the placenta, and if they're positive, specifically like 2 or 3 times the upper limit of normal, those confer an increased risk of fetal and neonatal thyroid disease. So those are the ones that have a clinical impact. There are many, many types of anti-thyroid antibodies, and the two most common that will come up are thyroglobulin antibody and thyroid peroxidase or TPO antibodies. They don't usually cross the placenta. They might not, but those aren't associated with fetal thyroid disease. They do confer a slight increased risk for mom to have thyroid disease, but nothing that we're gonna really change management on. So this is from the ACOG practice bulletin, which is the anti-thyroid antibodies, just the type 2 I talked about. They're in up to 20% of reproductive age women. Most of those women are completely euthyroid, and routine testing for them when you're euthyroid is not recommended. That is very different than the first ones I explained, which are women who have Graves' disease. Their whole pathophysiology is based on these TSH receptor antibodies, or I'll refer to them as TRAbs, and that's like why they have Graves. So you have these autoantibodies that are stimulating the thyroid. And if your TRAb levels are 3 times the upper limit of normal, those babies have a higher risk for fetal and neonatal Graves. So those are the ones where we need to, if their TRAbs are positive, PEDS wants to know. Some people advocate for a little closer monitoring of baby. Like those are the people who are at risk for neonatal goiter and neonatal Graves. So those TRAbs cross the placenta, they bind to the thyroid follicular cells, and they can alter fetal thyroid hormone. And the key thing is they can either activate or inhibit. So you could have a baby born hyper or hypo. It just depends on what that TRAb is doing.
Serial testing of these or no? Like a one.
So it is very controversial, and we don't do this, but like Up to Date advocates for you test them like prenatally and then again at like 20 to 24 weeks to see like what is happening. And that's mainly some places will use it to tailor monitoring for more frequent monitoring of like a 3rd trimester growth. And definitely an assessment for peds, because pediatrics will definitely want to know because they'll test the baby.
One of the issues that different labs report them differently.
Yeah.
It gets very confusing. So 3 times normal is correct. And the way I've seen it, I like to see it, it's in percentage. Like if it's about 300%, like if it's 400, 500, 600, which you'll see, then it could be, fetal hyperthyroidism. And so some people look for the goiter, they may look fetal heart rate, to see if the baby's affected, do growth ultrasound, because they can be FGR. I like to send them. But again, I'm get confused because some labs report it differently, and then it's really hard to.
Yeah, and it's also confusing because you have to send like the right kind of antibody, because TPO antibodies we don't care about. It's the TSIs and the TBIs. And obviously every lab is like labeling them slightly different.
Only if they have Graves' disease.
Specifically only if they have Graves. But the key part here is, and this is why like history is so important, is like there's some people who've had like an ablation, so their original pathology was Graves, but now they're hypo. So it's like getting back to like, okay, what was the original diagnosis? But yes, in Graves, it's important to look at their TRAB status. So just to touch on maternal hyperthyroidism, just a review, we all know this, but it's bread and butter. You're gonna have a low TSH and a high free T4. 95% of the time, the original pathology is Graves. So you have your TSH receptor antibodies, your TRABs, which stimulate the thyroid hormone or stimulate thyroid hormone synthesis and secretion, and they also stimulate the thyroid to grow. The treatment is going to be your thiamides, which is PTU and methimazole. Those are like your mainstay treatment. So you're looking specifically at the free T4, and you want this slightly above normal or your high normal range. And this is specifically because, especially in the first trimester, like that T4 is what the baby is getting. So you don't want to have a really low T4. You're not following the TSH, and some types of Graves are T3 predominant. So, and this is not the norm, but sometimes you do monitor T3 depending on the Graves disease phenotype. So this comes up all the time, but how do you choose a medication? Methimazole, the teaching is that you avoid in the first trimester because of the rare embryopathy. You can have esophageal and choanal atresia and aplasia cutis, where you have like failure of skin to form on the scalp usually, but it can be all on the body. There was a study that was published that showed a 2-fold increase in major fetal malformations in those exposed to methimazole in the first trimester compared to PTU. So that was kind of what those risks make methimazole not the first line choice in the first trimester. In the first trimester, we use PTU. There is a risk of maternal hepatotoxicity, which is why some advocate for it not to be used the rest of pregnancy. However, it is preferred if you have T3 predominant thyrotoxicosis, and this is because it decreases conversion of T4 to T3. The transition from PTU to methimazole is somewhat controversial. It doesn't always happen, and depending on the endocrinologist, I've seen people stay on PTU their entire pregnancy, and this is because they might have poor control with methimazole, so you want the mom to stay on the medication that works for her. There are rare side effects that will definitely get tested on for boards, and these can happen with either. There can be transient leukopenia in about 10% of patients, but you don't have to stop the meds. However, if there's agranulocytosis, which is very rare, about 1%, you're going to stop the medication. It's not dose dependent, and moms will report fever, sore throat. You're going to send a CBC. So just a rare side effect to look out for. So just to touch on maternal hypothyroidism, that's a high TSH and a low free T4. We're following the TSH. The mainstay treatment is you're replacing the T4 in the form of levothyroxine or Synthroid. We can anticipate that this will increase for all the reasons we talked about. An anticipated increase of 25% at pregnancy confirmation is expected, and you'll see sometimes endocrinologists will like bump up their levothyroxine once they become pregnant. And we're following the lower limit of our reference range, which the range would be lower limit of reference range to 2.5. I think Moti has a thing about TRABs. He says positive.
Oh, just mentioning, yeah, about the like you mentioned the chain, the terminology can be confusing.
Yeah. The only antibody that matters is TSI. Test those with history of Graves, hyperthyroidism in pregnancy, or neonatal hyperthyroidism. Yeah, so when we order, we should really be looking specifically at TSIs. Thank you.
Let them use the word whack.
I
Just
hope
like
so.
his ad lib comments, yeah.
Okay, we're going back to the baby.
I like the big.
Yeah, that's my fetus. Yeah. Be a professional soccer player. Okay, so now we did our background. We're talking about the fetus now. So the definition of fetal goiter is a thyroid gland where the width and circumference exceed the 95th percentile for gestational age. So you're going to be looking for an anterior neck mass that is symmetric, homogeneous, and hyperechoic. And it's usually seen after 20 weeks gestation. And that is because, as we talked about, that's when the fetal thyroid is like finally functional. So your little goiter checklist is you're going to look for size. You're going to measure the circumference and also the transverse diameter. You're going to look for vascularity. So you're going to throw on your Doppler flow. You want to look at the size of the trachea and specifically, is it patent? And then you want to see presence of fetal swallowing, because what can happen is the goiter can get so large that it can be obstructive and the baby will no longer swallow and the esophagus and the trachea can be compressed. Now, your next challenge is then to figure out, is this fetus hyper or hypothyroid? And you can't tell just based on size what is happening. So some other findings in more detail: the fetal neck will be hyperextended, and I'll show you a bunch of pictures. The trachea and the esophagus may be compressed or displaced, and that can cause polyhydramnios later on. On color Doppler, this is like a subtle finding, but there's reports that diffuse increased flow is more seen in hyperthyroidism versus increased flow only to the periphery is with hypo. Utilize 3D to really map the neck. And then also nomograms exist for the thyroid volume by gestational age. And I included one. It's just on another slide. So fetal goiter is extremely rare. As I touched on, you can't automatically tell the fetal thyroid state. So most commonly it's seen in fetal hypothyroidism, but babies can be hyper, or rarely they can be euthyroid. If you see a fetal goiter, 90% of the time, it's caused by maternal Graves' disease. And this was an article in 2009, which this seems extremely high, but they say that 19% of fetuses have a goiter in mothers with Graves' disease. That seems super high to me.
Uncontrolled Graves' disease?
Yeah, so this is the thing, is it doesn't, I would have to dig. I didn't look to see uncontrolled, but it actually like can also be if mom is controlled, right? Because it's these antibodies that are there even if it's controlled. Yeah. So the causes, your differential of the causes of fetal hypothyroidism are going to be, so this is in moms with Graves. So the reasons that their baby could be hypo is transplacental passage of methimazole or PTU. So mom is taking these medications, she needs to be on them, and they cross the placenta and they cause hypothyroidism in baby. Other causes can be transplacental passage of maternal thyroid gland blocking antibodies. You can have iodine deficiency, inborn errors of thyroid metabolism, maternal lithium use. And basically what's happening is the fetal thyroid is insufficient. So it has low thyroid hormone. So the baby makes its own TSH, which then stimulates the baby thyroid, the fetal thyroid, and that's why you get a goiter. So that's different than fetal hyperthyroidism. So that is the transplacental passage of these maternal TRABs or TSIs, they are crossing the placenta and they are stimulating the baby's thyroid. So you have goiter because you're having stimulation, and you're also hyperthyroid because the baby's thyroid hormone is increasing from that stimulation. Other causes that are more rare are McEwen-Albright syndrome, and there's some autosomal dominant forms of hyperthyroidism. And as I talked about, the pathophysiology of it. Okay, so now we have some pictures. So this is a view here where you can see like an axial view of the fetal neck. You see the C-spine there. The thyroid circumference is measured, and the measurement is along the periphery of the thyroid and includes the trachea, which that is what this arrow is. That's the patent trachea in the middle of the thyroid. This is the thyroid circumference nomogram, and these are, you can readily look them up. And this is thyroid circumference that they're reporting. So these are other ultrasounds that you may see. So a sagittal view of the fetal neck. You can see that baby might be in persistent neck extension, and there's an anterior neck bulge that should not be there. Again, another image, baby is extended, and you can see the goiter. This is like really obvious. This is another view of the thyroid here. You can see the two lobes here of the thyroid that I've circled. Trachea here. And then you can also see that they're smooth, they're uniform, and they're equal bilaterally. Again, another picture, you can see this is the lobes of the thyroid, the isthmus of the thyroid, the fluid-filled trachea. Your carotid arteries, which are here in the blue curved arrow, will be displaced posteriorly. This is a transverse view of the fetal goiter, and you're gonna put on your Doppler, and this is showing diffusely increased flow. This is a 3D rendering where you can obviously see the chin is extended and the baby has a goiter. Another 3D view. So utilize your Doppler, utilize 3D, utilize like multiplanar view. So the sequelae of fetal hyperthyroid are fetal growth restriction. You can see accelerated bone maturity. You can see sometimes craniosynostosis, where you have premature fusion of the fetal sutures. And this is more of a specific finding for hyperthyroidism. You see signs of thyroid toxicosis, so fetal tachycardia. You can see cardiac failure or hydrops. And if you have a hydropic baby, increased risk for preterm birth, IUFD, and neurologic sequelae of that. Fetal sequelae of hypothyroidism would be delayed bone maturity, intellectual disability, hearing deficits, poor visual motor skills, delayed speech and language development, and poor attention and memory skills. So more of your like neurodevelopmental issues. I touched on our ultrasound imaging, but there is role for MRI if you have a large fetal goiter. So this is the best way to assess the airway and also risk of esophageal obstruction. So the trachea should be seen as a fluid-filled column. If you don't see this, babies are at increased risk for airway obstruction at birth, and I'll show you some pictures. Also, the different signaling of the MRI is important. So T1 signaling helps differentiate goiter from other neck masses, which will be on the differential. So goiter, the goiter will be homogeneous and will have an increased signal compared to muscle. T2 signaling coordinates with iodine concentration. So high iodine concentration has a low signal gland. So that gland will be darker or the same as muscle. And you see that more in a hyperthyroid state. Low iodine concentration has a high signal gland, so it will be brighter than muscle, and that's more with hypothyroid. And I'll show you pictures. So this is a T2 MRI. So with this, the goiter is a low signal intensity, and the purpose of this was really to see that the oropharynx here is distended due to esophageal and tracheal compression. So you're not able to follow it all the way down, and this baby's at risk of polyhydramnios, difficulty swallowing, or airway compromise at delivery. This is another T2 MRI. So the thyroid is the same or darker compared to muscle. So you have muscle here, and that's what you see more in a hyperthyroid state. But the key here is you see this patent trachea, which is good. This is a T1 image. So you see high signal intensity throughout. And this, so T1 MRIs are to help differentiate other neck masses. So this is the high signal intensity is characteristic of a fetal thyroid mass as compared to like a cervical neuroblastoma or some things that are on the differential. This is a T2 MRI. So this is the same case, it's just different weighting. So you can see here, the thyroid gland is higher signal intensity compared to the muscle, suggesting hypothyroidism. So for your differential, you're really going to think about, okay, what are other masses that can happen in the neck? And the most common one would be a cervical teratoma. However, it's going to be more irregular shaped. It's usually going to extend above or beyond the region of the thyroid. You might see mixed echogenicity. It may extend into the mediastinum, and it's going to grow rapidly. Neuroblastomas are very, very rare, but they're usually more posterior and they're more heterogeneous. And then some other on your differential would be a thyroid cyst, a hemangioma, ectopic thymus, a branchial cleft cyst, a cervical meningocele, or a cystic hygroma. Okay, so we've identified a fetal goiter. Your next big challenge is to evaluate the function of the fetal thyroid, because you can do all of this imaging, but you still don't know for sure what's happening with this fetal thyroid status, and that guides treatment. So there are two things you can do. You can either do an amnio or you can actually do a PUBS. So amnio is less accurate overall, but there's less risk. So maternal TSH doesn't cross the placenta, as I talked about. Therefore, amniotic fluid TSH levels reflect fetal TSH. However, there are discrepancies between the amniotic fluid and the neonatal blood TSH levels. So that kind of gets a little controversial. Thyroid hormone levels from amniotic fluid do not accurately reflect the fetal thyroid gland function. So here you're mainly looking at TSH. And this is a paper that talks about like the reference ranges for specifically TSH from amniotic fluid. So just a resource. The gold standard for diagnosing the fetal thyroid status is doing a PUBS or a cortocentesis. So this enables accurate and direct measurement of fetal thyroid hormone levels. However, as we all know, it has higher risk for complications compared to an amniocentesis. And there are published levels that we can compare them to. So once you find out like what kind of type of fetal status you're dealing with the goiter, you can tailor treatment. So a large fetal goiter needs to be treated because it can cause tracheal obstruction that can cause neonatal death. And you can also have fetal neck hyperextension, which can cause mechanical issues at delivery, like with a dystocia. And if you tailor treatment in pregnancy, you can reduce the size of the goiter. So treatment for fetal goiter caused by hyperthyroidism is you give moms thiamides. So you give mom PTU or methimazole. So these medications cross the placenta, they act on the fetal thyroid gland. PTU is your first line treatment. Your goal is to resolve the fetal tachycardia or any evidence of thyroid toxicosis that there might be. You monitor the size of the goiter. If maternal hypothyroidism develops, you actually add levothyroxine. So you're trying to keep mom euthyroid while also treating the baby. If urgent fetal treatment is needed, you can give potassium iodide. If there's fetal thyroid toxicosis, you can also give propranolol to mom. However, we know propranolol can cause fetal growth restriction, neonatal bradycardia, hypotension, hypoglycemia, and neonatal jaundice. But if you have like a really, really sick baby, there are other things that we do. So treatment for hypothyroidism in the context of fetal goiter, you can't just treat mom. So you ask mom to stop or reduce her PTU or methimazole, right? Because this is probably what's happening is the PTU is crossing the placenta and causing hypothyroidism in baby. And you can't just give mom more levothyroxine because this placental transfer is minimal. So what you actually have to do is you have to give intraamniotic thyroid hormone directly to the baby. So these are intraamniotic injections of levothyroxine, and the baby swallows and ingests the levothyroxine, and that is how you treat that. So the bad thing is, while you might like decrease the size of the goiter, effective treatment doesn't always prevent hypothyroidism at birth. This is a great paper which talks about the dosing and different case studies of intraamniotic levothyroxine administration. It's just like a big table and it's really small, so you can look at it at your own time. So when you have a baby with goiter, you're going to be doing serial sonographic surveillance, which will include echoes and assessment for fetal heart failure and high drops. You're going to be doing serial growth ultrasounds and antenatal monitoring, and this is proposed twice weekly NSTs. Delivery planning will really go based on the fetal phenotype. So massive fetal goiters may cause tracheal compression, and you have options. Sometimes you need a cesarean to minimize the risk of like a neck dystocia. You might have to be prepared for emergency tracheotomy or bronchoscopy in the delivery room. I know CHOP in the thing that we just saw talked about their exit procedures that they do to establish a fetal airway. And then there's also been case reports of fetal endoscopic tracheal intubation. So you form an orotracheal cannula with fetoscopy, and then when babies are delivered, they already have their established airway. This is from that same great paper I talked about, and they talk about like the outcomes of different exit procedures for fetal goiter. And now I'm just going to touch briefly on things about the baby.
Genetic.
Yeah, there are, which I'll talk about. So specifically, there's like congenital hypothyroidism, and that's part of like newborn screening. Yeah, so I talk about that. So what happens when the baby is born is birth into this cold outside world causes the hypothalamus to secrete TRH, thyrotropin releasing hormone, that stimulates the baby's pituitary to secrete even more TSH, and you see a huge TSH surge by 30 minutes of life. So you're doing skin to skin and the baby's surging with its TSH. And that TSH surge then causes the baby's thyroid to make its own T4, and this peaks on day 2 of life and then normalizes thereafter. So this physiology explains why we screen for congenital hypothyroidism on day 2 through 4 of life. So this is part of universal newborn screening, and it has been since the 1970s. And this is 1 in 4,000 live births, and congenital hypothyroidism can cause like severe intellectual disability, like neuromotor growth issues if it's not identified early. So this is like universal newborn screening is performed on days of life 2 to 4, a little later in preterm neonates, and they look primarily, they test fetal TSH, and then their backup method is to test the T4. So this is part of universal newborn screening. But if you test too early, you're gonna see a falsely elevated TSH because the babies do the little surge once they're born. There's also a phenomenon called hypothyroxemia of prematurity. So specifically neonates born before 34 weeks have a lower T4 compared to normal term neonates. Neonates is because the hypothalamic pituitary thyroid axis is just immature. They have an attenuated increase in T4 in response to the TSH surge. So they're still doing the surge, they just don't make as much T4. This is usually a benign finding and it's transient and gradually resolves. But this can explain why we wait until day of life 7 to test preterm babies. There can also be a critical illness that is causing hypothyroidism in baby. So bacteremia, lung disease, or neck. The T3 is more affected because of inhibition of conversion of T4 to T3. So now I'm going to just touch on neonatal Graves. So this is in 1 to 5% of neonates born to moms with Graves' disease. So the pathophysiology is you have in utero exposure to high T4 and T3. So you're having these thyroid stimulating antibodies activate the fetal TSH receptors. The fetus upregulates its own fetal thyroid hormone production, and then it's at risk of hyperthyroidism when it's born. And you can have a delayed presentation of this because baby was exposed to the thiamides, the PTU, and the methimazole, and this wears off, but the maternal stimulating antibodies stay around. So you can have a delayed presentation of this because there's like a little honeymoon period while the maternal thiamides are still in the baby. You can also have neonatal hypothyroidism. So this is in 10 to 15% of neonates born to moms with Graves' disease that are on medication. The neonates can develop a transient hypothyroidism. This is caused by the medications that mom is taking, but there are also antibodies that can inhibit the neonatal thyroid. They're not as likely, but they do exist. And those are some of my references. And I hope you guys enjoyed my thyroid review. So I think for me, the big thing is I'm going to pay more attention to my TSIs now.
And the other thing is that when you were mentioning that the goal of treatment is to avoid also tracheal compression, is also to avoid the neurologic damage, especially if they're hypo.
Yeah. Yeah.
That was outstanding, Katie.
Thanks.
Outstanding. So good. I think Moti had his hands up. Is that correct?
No, I was just using the emojis for a great job.
Oh, there you go.
Thank you.
Like clap, this is actually pretty fun.
Oh yeah, I like that.
My time I've done one time I went to try to give T4 amniocentesis.
Yeah.
So you're not gonna see it often.
No, I like truly have never even heard of it. I was like, this is
I know.
wild.
Yeah, no. We ask it at boards all the time. We
Yes,
have that
you
scenario
do.
all the time because it's interesting. But truly, you're not gonna see that many, but I agree with you. I wish we actually had more SMFM, etc. guidance. Because really with hyperthyroidism, which you're gonna see most of the time,
Yeah.
maybe that's okay, those antibodies don't really make a difference.
No.
But, when you have elevated TSI, which somehow you or somebody has said, they're 3 times normal, like you say, then most of this comes up.
Exactly. Yeah.
And you're treating, and, but how often, for example, you do ultrasounds?
No guidance. Yeah.
How much guidance, how often you do growth ultrasound? You have to measure the thyroid every month or all in the trimester. There's not that much. Yeah, what's the cutoff for fetal heart rate?
Yeah.
That you're monitoring. But and again, I don't even know the numbers. I in my experience, it's probably half and half, but I'm probably completely wrong. In terms of if you send TSIs, how many are above 300% versus or 3 times?
Yeah. I don't know.
versus
I'm
normal.
sure it exists.
That
I
would be
just
my
don't
growth.
know.
Completely probably abnormal. So some of them you send them and they're fine. And like you said, you repeat them, you don't. But when there are, and you see, maybe half the cases that you see them elevated, then I think you should monitor.
Yeah.
Or the neck, the extension, and it becomes.
And especially important for like the pediatricians when baby is born, like to monitor baby because they are at risk of like hypo and hyperthyroidism.
That was amazing.
I'm glad. Well, I had some of these thyroid consults and I was like, I know how to treat mom, but I was like, let's just do a little baby dive.
And it's really important. Thanks for everybody for joining also from the genetic counseling people. Do we have neonatology to do babies? See them.
Oh, I don't know who's Kevin George,
I
but
don't know the students.
Yeah. If not, Rodney, do you wanna jump in and do your thing? Or unless maybe Katie and a patient, but she just stepped out. So why don't you take on and then we'll go back to patient.
All right, let me share my screen.
I should have preconception, but it's fine. And there's some food guys. Bagels and something so I couldn't resist. As usual.
All right, you guys able to hear me?
Yeah.
All right, so I'm going to talk about timing of delivery in pregnancies complicated with diabetes. So I have 3 objectives this morning I want to go through is to review the current recommendations, of course, take a dive into the evidence, and then review and finalize my proposed guidelines that I'll present to the OB guidelines meeting later this month. So when it comes to deciding timing of delivery, there's always things that we are deciding on, balancing. Most times we're thinking of, maternal risk, fetal, neonatal risk. When, thinking specifically for diabetes, I think it's slightly different in that we're thinking of, fetal versus neonatal. So, we don't want to deliver too early because then we increase the risk of, prematurity, neonatal, morbidity and death. Oh, it's not advancing. But on the other hand, we also want to deliver a live baby that we could help, transition and not just continue the pregnancy until, and, take on more risk of stillbirth. So as I'm going through everything, this is our main goal, our main objective for you to keep in mind when we're, deciding on the timing of delivery for these pregnancies. So let's review what the professional societies say first. So ACOG, pre-gestational diabetics, uncomplicated, they recommend delivering the 39th week. If they are poorly controlled with vascular complications or prior stillbirths, they recommend anywhere between 36 and 38 and 6. In terms of GDMA, well-controlled, not on meds, they say anywhere up to 40 weeks and 6 days. On meds, they recommend the 39th week. And if they're poorly controlled with GDM, they recommend individualizing. Looking at across the ocean at the green top guidelines that our COC uses. For pre-gestational diabetics, they recommend offering induction at 37 to 38 and 6. For pre-gestational diabetics that are complicated, they just said offer induction before 37 weeks. Gestational diabetics, they say don't deliver later than 40 weeks and 6 days, and they don't really differentiate whether they're well controlled or poor controlled. In terms of the Canadian Diabetes Association, they kind of just make a general statement, when making a decision regarding timing of delivery before 40 weeks, the benefits regarding prevention, with regards to prevention of stillbirth and a possible decrease in C-section rate need to be weighed against the likely increase in neonatal complications, which is slightly outdated because we now know more recent evidence that induction doesn't necessarily increase your risk of C-section. The American Diabetes Association, in the most recent, management guidelines, they don't even mention anything about time of delivery in terms of pregnancies with diabetes. And the JOGC, which is the Canadian group, they just say offer induction at 38 to 40 weeks. Obviously a wide range, and whenever we see this, it's there's always a reason, and it's probably just the amount of evidence that we have available to make those decisions. So in terms of our current guidelines that was recently done by Janine, it's listed here. It's mainly based on the ACOG late preterm, early term delivery recommendations. So let's dive into the evidence. So, believe it or not, there's actually not a lot of evidence on this subject. There's only 2 small RCTs that we'll, of course, review. So this first one, this is an RCT of patients with gestational diabetes or pre-gestational diabetes that was done between 1987 and 1991 and was published in 93. They randomized 100 patients to induction at 38 to 39 weeks versus 100 patients that were expectantly managed. Their criteria, which I think is important to review, and we'll review with the other RCTs, they included patients that were on insulin who were at least 38 weeks and that had good glycemic control, which they defined as 90% within range, and the EFW was less than 3,800 grams. They included both gestational and pre-gestational diabetics, but a majority of them were gestational, and there were only 13 pre-gestational diabetics that were in this trial. And importantly, the patients that were in the expectant management group, they were followed closely and delivered for preeclampsia, or if they developed hyperglycemia, or if their EFW was greater than 4,200 or up to 42 weeks. So their findings were not so impressive. Of course, the induction group delivered a little bit earlier, but if you look at the range, it's 38 and 6 to 39 and 2 versus 39 and 6 and 40 and 2. The only difference was LGA. Of course, in the expected management group, there was more LGA. Importantly, they did not have any perinatal deaths. They did have 3 shoulder dystocias that had no long-term sequelae, and those all occurred in the expectant management group. So they concluded there appears to be no advantage in delaying delivery in women with insulin-requiring diabetes past 38 to 39 weeks. But if delivery is postponed, careful monitoring of size and growth should be performed. So the other RCT on this subject, this was a multi-center RCT at 8 teaching hospitals in Italy, Slovenia, and Israel, where they randomized patients to immediate delivery at 38 to 39 weeks versus expectant management. So again, their eligibility criteria, they only included gestational diabetics that were diagnosed by the DPSG criteria. They had to be, of course, 38 to 39 weeks, and they had an EFW of less than 4,000 grams. And their expectant management group was similar to the prior study where, they delivered for like preeclampsia and all the things. Their primary outcome was a C-section, and they found no difference in C-section or operative delivery. In terms of neonatal outcomes, there really wasn't any much difference. Of course, they delivered earlier, or the more patients delivered more than 39 weeks in the expected management group. Macrosomia was slightly increased, but it didn't reach statistical significance. But in terms of, shoulder dystocia, NICU admission, respiratory distress, there was really no difference. So this study was published in 2016. They did make an important note. So their initial sample size was to include 880 per group, but they state, the obvious obstacles to recruiting pregnant women at such a delicate moment were evident during the recruitment phase. Thus, the time period was, much extended than they had anticipated, and they ended the study earlier after 4 years. So they only had, 200 in each group. Nonetheless, they still concluded that their results are transferable to low-risk GDM population, and that the results suggest that there's no clinical difference between birth outcomes that were expectantly managed versus actively managed or induced. And there, even though it was a small sample size, the difference between those difference was not clinically relevant. Doesn't really leave us much information to go by. Both these trials were well controlled, mainly gestational diabetics. So I looked into other retrospective studies and found this, I think, well done. Population studies. Of course, with population-based studies, there's always limitations. But this was a population study looking at a Canadian database. So what they did was at each week of delivery, they looked at the pregnancies that were delivered, like iatrogenically, like induction or pre-labor C-section compared to, and compared, outcomes between the patients that delivered after that week, whether they were induced or whatever. So it's kind of, creating that scenario where you have a patient in front of you, 36 weeks, do you induce or do you just wait? And they excluded the ones that were spontaneously delivered at each of those weeks when they did their comparisons. They mainly compared composites of maternal morbidity and neonatal morbidity that are listed here. I'll go into a little bit more of that later. So what they did was, for each pregnancy complicated with diabetes, they looked at, they compared at each week, the rate of these composites, which I'll, go through. So, women with pre-gestational type 1 diabetics, you can see maternal morbidity, even though you do see differences, they were not statistically significant. In terms of neonatal morbidity, those that were delivered at 36, 37 weeks had higher morbidity, and the difference was gone after 38, 39 weeks. In terms of type 2 diabetes, no difference in maternal morbidity, whether they were actively managed or not. But neonatal morbidity, if they were delivered at 36 weeks, they had a higher rate. But at 37, 38, and on, there was no statistical significance. In terms of gestational diabetes, looking at, again, the neonatal morbidity, at each week, there was statistical significance. So at 36, 37 weeks, the rate was higher in those that were delivered versus 38, 39, 40. If they were induced at the period, they had a lower rate of morbidity. So they, concluded that their data suggests that, delivery at 38 to 39 or 40 weeks may optimize neonatal outcomes among women with diabetes. Of course, this is a Canadian database. There's we have a much different population on average, US, patients are more obese. We know that obese has its complications. This is a CDC graph showing that in the US, the BMI or the obesity rate, it's about 36% of women have obese versus 24% in Canadians. We know that there's risk with stillbirth. At each at each increase above BMI of 25, your risk of stillbirth is higher than if they had a normal weight. And I think one of the limitations of that population study, even though it was well done, I think, and this may be simplifying it too much, but their neonatal composite, they lumped everything into one, which I think really it should be separate, because on one hand, in the expectant management group, we're worried about stillbirth, we're worried about birth injury, we're worried about shoulder dystocia. But in, the active or, inducing early, we're worried more about, like IVH, respiratory distress. That, neonates that are born from diabetes have, delay lung maturation. So those are kind of the things that, we want to, kind of balance out, and they kind of just lumped everything together. There's this was a recent study looking at fetal death certificates that was just published this month in the Green, which I think is really important, and it's also helpful when thinking about this guideline. It was taking the death certificates between 2014 and 2017. Yes, and one of our fellows, there's Emily Oliver. So this graph summarizes the whole data. So, pregnancies with pregestational diabetes and gestational diabetes stratified by their growth, whether they're AGA, LGA, or SGA. Pregestational diabetes are the ones that are in the blue, and in the green is the gestational diabetes. The y-axis is the fetal death per 10,000, and the x is the gestational age from 34 to 39. So just by looking at this graph, you can see that stillbirth increases with each increase in gestational age, but you could clearly see a huge difference between the pregestational diabetics that had growth issues, LGA or SGA, compared to everyone else. So that's very important to consider. You see after 36 weeks, it's just markedly increased. I looked into their supplement data to kind of get an idea of what the absolute risk of these stillbirths and neonatal deaths was, just to help decide between the balances. I took all of them, and I took the stillbirth rate at each week, and I looked at the neonatal death at that time, and the expected stillbirth is all the stillbirths that happen after 37 weeks over the ongoing pregnancies after that week, just to kind of get an idea, see if there's a way where you could balance, both death and expectant. In terms of GM with AGA, you can see there's not, too much of a big difference, which we anticipated. LGA, also not a large rate of stillbirth. And just to kind of give you some context, stillbirth with FGR, less than 10 percentiles report around 1.5%, versus, and less than third percentile is much higher, it's 2.5%. That just kind of gives you an idea with these numbers. I just have them all listed here. In the pregestational diabetics AGA, you see that's slightly higher than the gestational diabetics, even those that had growth issues, but overall, relatively low. It's when you get to the LGA and especially the SGA that you see the rate that each week is, relatively high. And even the neonatal deaths at that time are also high. And then of course with the SGA, that's the biggest, that's where you have the biggest increase. But again, this is still just a small part of the picture. It's not the full picture because, to get back to that balance, we want to know, neonatal death is important, but it's also the morbidity and, like NICU admissions and such that I think could also help us decide. So what I did is I looked at the vital statistics data of live births with pregnancies with pre-gestational diabetics and gestational diabetics, those that delivered between 36 and 41 weeks. Again, kind of, taken from the design from that Canadian population, looked at each week, induction or pre-labor C-section versus those that delivered after that week. And, excluding the spontaneous ones that delivered at that week. I looked at composites of maternal and neonatal outcomes that were available on the birth certificate, and then I kind of stratified it by the growth since we have that nice stillbirth to kind of help our decisions. So I included 1.2 pregnancies. There was about 130,000 pre-gestational diabetics and about 1 million gestational diabetics. And then I, did this similar thing. So in terms of pre-gestational diabetics that were AGA, you can see that the morbidity composite was, higher if they were delivered at 36 or 37 weeks, but then it became, not significant at 38. And was significant in those who were induced at the 39th week. In terms of more maternal morbidity, the only difference was seen at the 36th week, but there was no statistical significance at later gestational age. In terms of LGA, the composite sees, increase with 36th, 37th week, but at 38 and 39 weeks, that's when it becomes statistically significant. The 39th week was lower, but it didn't reach statistical significance, and there was no difference in maternal composites at each week. In terms of gestational diabetics with AGA, in terms of the neonatal morbidity, there was statistical significance at each week, where if they were delivered at 36, 37, 38 weeks, they had higher versus those that were expectantly managed, but at 39 weeks, that switched over to those that were induced at 39 weeks had better outcomes than those that were expectantly managed. And then we see that there was, for maternal morbidity at 36, 37 weeks, there was increased risk if they were induced, but that's later, at later weeks, there was no difference. In terms of LGA, again, 36, 37 weeks with patients with gestational diabetics induced, they had higher risk of morbidity, but that becomes non-significant at 38 weeks, and then it turns over at 39 weeks. So again, thinking about, this risk of prematurity, early term, and, the risk of, stillbirth, these are what, I propose as our guidelines. So for pre-gestational diabetics that are well controlled, which I think should be defined as, AGA fetuses, and that do not have poly, they should be delivered at, by 39 weeks, just because of that risk of, stillbirth. In terms of pre-gestationals that's not well controlled, so if they're LGA or if they have poly, then I think we should, recommend delivery between 38 and 36 weeks. I added this category just because of that, the study that showed that there was that marked increase with FGR. Currently our guidelines, say from, 3rd to 10th, we say anywhere between 38 and 39 weeks. With concurrent conditions, it's a wide range between 34 to 37 and 6. And remember at, 36 to 37, it's the it's the dotted blue line is the SGA with pre-gestational. At 36 to 37, it kind of makes that big jump. So I proposed 37 to 36, but I'm also, and I'd love to hear your thoughts, I'm also okay with 36 to 37. But, with the FGR, I think with the other FGR categories, I think those will just dictate the delivery managers. This is just patients that just have strictly FGR, but normal Dopplers and normal testing. And then in terms of pre-gestational diabetes with, vascular complications like renal disease, chronic hypertension, history of stillbirth, I think those should be individualized because there's so many different factors that you have to consider that I think those should be individualized. In terms of gestational diabetics, well-controlled, same criteria as I spoke before, AGA, not poly, 39 to 39 and 6. Not controlled by the same criteria, 38 to 39. Open thought and discussion. I just put everything out here so we could discuss.
Would you distinguish gestational diabetes well-controlled, like as in on medications or off medications?
I don't think so. I mean, it's, the RCT data, all of them had, or the first RCT had patients had to be on insulin. So those were, patients that were on meds. I think on a whole, I don't know if there's really any benefit waiting for an A1 to deliver at, 40 weeks. I think with A1, I think you do have a little bit more leeway, but
Yeah.
I just think with, the evidence with, 39 weeks, I don't know if we're really gaining much waiting past 39 and 6.
Yeah, I mean, I just think there's some people who are A1s who are overall healthy who aren't gonna wanna have an induction at 39 weeks.
Yeah, and these are like, guidelines, patients don't listen to everything we say, but that's just, our suggestions. And of course, as long as they understand the risk, then just document that.
Going from top to bottom, Rodney, we can do it that way to be efficient. So pre-gestational well-controlled, by 39 weeks could also be 36 weeks. I will put a range like you do for everybody else.
Okay.
Are we saying, 38 and 0 to whatever, what would you suggest?
Or the first one, the well-controlled?
Yeah.
Well-controlled, I mean, I would, we could probably just do 39.0 to 39 and 6. Because at 38 weeks, I don't think, if they're well-controlled, it's very important that they're, well-controlled. They don't have any fetal growth abnormalities. They don't have poly or any suggestions of not being controlled. I think those can go 39, 36.
Okay, so 39 and 0 to 39 and 6, okay.
Mm-hmm.
Next one, not controlled. Some people would argue if it's really, poorly controlled, even earlier than 38 weeks. Let's say somebody has, continuous sugars into 200, non-compliant. I forgot what the other. I hate to have a big range because, some of the guidelines you showed, either talk about 34 weeks or 36 weeks. I think that helps to have a big range. I'm happy with a smaller range.
Okay, I think for progestational not controlled, I would put like 37 to 39.
Yeah.
I feel like we do that now.
Yeah.
Yeah. So maybe
Okay.
37 and 0 to 38 and 6.
Okay,
You taking notes?
yes,
I think the next one makes sense, given the data you showed. Any comments on that? 37, 0, 38.
No.
Next one, individualized, makes sense too.
Mhm.
Different. Then the common one, gestational diabetes, well controlled.
Yeah.
I think that's good. People okay? 39, 0.
I just think we differ from like ACOG in this, in that they do distinguish diet versus medication, and diet, they go to 40 and 6. So this is like really, it's pretty different.
I think we're not recommending going past your due date to anyone, right?
Yeah,
I mean,
right.
given that rock trial and everything else.
I
That's
have
what-
thoughts, but I will save them.
I mean, it is, it's always a conversation with the patient. It's a recommendation, but their experience. If they want to wait, but I don't know if we should recommend, delivery. That's my thing with the guideline.
Yeah, just like what is the, I guess for a person who's GDMA1 well controlled, not on medication. Aside from like the evidence with the ARRIVE trial, what is her increased risk in waiting a week? Like that's what they're gonna ask us.
Yeah, so it's mainly just the stillbirth risk, because it starts to, it's relatively stable, but then at the 39th week it starts to go up, and they don't have the data for after 39 weeks, which I think would help even solidify that. But the fact that it starts to increase at 39, even though it's a rare event, it's still something that
Remind me, for that GDM, do they include then 1 and 2 for those GDMs on that?
so there was no way to, it was both A1 and A2. There's no,
Because for me, that is a big difference. I just wanted to throw it out there.
I mean, there's 12 more years to go till the
Yeah.
ARRIVE trial will go into practice, because
Yeah.
we're only 5 years out. It takes 17 years for evidence to change practice.
Yeah.
So I understand.
I mean, I just think there's nothing wrong with physiologic labor. Like that's what we're depriving people of.
Again, I think it's an ARRIVE discussion,
Yeah.
20% decrease in morbidity, decrease in preeclampsia, hypertensive disease, decrease in stillbirth if you look at big data. Decrease in C-section, significant.
Is our current guideline for like anyone, like we recommend delivery by your due date, or is it we offer delivery by?
It's a range. Let me oh, here it is. So right now we don't have anyone that is going past 40 weeks
Is it diabetic?
who are gestational diabetics. Yeah.
Right.
Well,
That's just
A1
different, like,
and
it's just
A2.
different than
Yeah,
A1.
ACOG definitely says to 40 and 6.
Yeah.
Yeah, ACOG was 40 and 6.
I just can see like the rest of the department asking that gestational diabetes A1 and A2 be like there be some kind of
It's separated.
Yeah, that's my main point.
I mean, they could ask that, but then we can show them that.
Yeah,
there's
it
a
could just use
distinction in the
that.
silver rate between A1 and A2. That's
But
what
that is already in our guidelines, no? What is the new recommendation?
Yes,
Up to
no, so
39?
it is, so it's essentially the same, it's the same, I'm just defining what well-controlled is. But it is what our guidelines suggest now.
Look together
They haven't
anyway.
said anything.
Yeah.
You can just separate it on your table.
Yeah.
Okay,
Because it's the same guideline,
but yeah,
I just disagree with those.
okay. So we'll see what sorry. All right.
You wanna go back to your table? It was one last time.
Yeah, there it is.
People, the last one, gestational diabetes not controlled. I think that makes sense. You wanna do 38 and 0 to 38 and 6?
There's-
Yeah,
Oh, okay. I mean, even the 38 and 6 instead. Okay.
and this will keep on shifting, as more data comes out.
Mhm.
That's so many diabetics have.
But also the gestational diabetes not controlled. I don't know, I feel that sometimes we deliver earlier than that. It's really uncontrolled.
Yeah, but those people also, yeah, uncontrolled and also
Yeah.
thinking like the influence of like hypertension too, which you do account for in the individualized part.
Right. Because these are just patients. These are, I mean, we don't have many of them, but they're like just, gestational diabetes. They're not with chronic hypertension or anything else.
Yeah, I feel like there's very few people who have poorly controlled pre-gestational diabetes who don't also have hypertension.
I agree.
And we tend to not call patients that may have pre-gestational diabetes, pre-gestational diabetes. We keep a lot of them gestational diabetic. So I can see Anna's points and Katie's points. There may be a gestational diabetic whose BMI is 50, who is on insulin, high doses, and she's not controlled. I guess the discussion is if to put 37 and 0 or 38 and 0. Right? That's what you're saying.
Yeah. We do 37 to 39.
Similar to the pre-gestational.
Yeah, I mean, if they're not controlled,
Okay.
assuming they're on medication, that's not controlling them. That's reasonable.
Okay.
Team decision always better.
Yeah.
All right.
All right.
Thank you,
Of course.
Rodney.
Great, thank you so
Thank you.
much.
Not an easy
Yes.
tackle. Can we go to Moti? I don't know, then, and he wanted to do his RCT. Thanks, Rodney, again, very much. Really important. As he puts his slides up, there is a diabetic society, right, in obstetric. Do they have guidelines at all, I don't think
Oh,
so.
sorry.
Yeah.
They don't. I don't think they have guidelines.
Okay.
Because I was trying to find, like other like organizations that had, guidelines, but many actually don't talk about the timing of delivery part. They mainly focus on like monitoring and things like that.
By the time you lead the society, they will.
Oh,
Not soon to be.
That's it.
All right, can you guys see?
Yes.
Okay, I may, if I have to leave, I'll mute, but I hope not. So again, this is a proposal for this randomized trial that I'd like to, second, I guess you see which view do you see?
Presenter.
Presenter.
That's fine. I'll just do it like this. It doesn't, because I'll be writing notes anyways. Okay, so this is an idea that I had for a randomized controlled trial looking at cerclage for short cervix at 24 to 26 weeks. As we all know, preterm birth, leading cause of neonatal morbidity and mortality. So we have all, risk assessment and prevention strategies. Our goal is to identify those at increased risk. And we know that patients with a short cervical length between 16 and 24 weeks identified via transvaginal ultrasound, less than 25 millimeters, are at increased risk. There are a number of various treatment options that have been studied in the literature, including progesterone, pessary, and cerclage. The focus here will be on cerclage, which we know is effective for patients with a short cervical length and history of preterm birth, less than 25 millimeters. And we know that also may be useful in patients with a short cervical length or progressively shortening cervical length in the absence of prior preterm birth. There's really 2-3 studies that are published on this. None of them were randomized trials. So that's why, we need more level of 1 evidence, and that's why the COLORS trial is underway and has been ongoing. And when you think about these strategies, most of these interventions were derived from randomized control trials on patients that were screened between 16 and 23 weeks and 6 days. But what about preterm birth risk when a short cervical length is detected after 24 weeks? Are those patients at increased risk? This was a cohort study that I published in the pink early on when it first came out, looking at patients with a short cervical length between 23 and 28 weeks. Stratified by cervical length measurement, and you see that a lot of these patients are still at high risk of preterm birth, less than 37 weeks, and that risk increases as the cervical length shortens. So we know that there is an increased risk of preterm birth in these patients. Another study that was done by Bergella, 2007, looking at predictive probability of preterm delivery before 35 weeks based on cervical length measurement and time of measurement, focusing here on the 24 to 26 week group. And you see that, again, there are high risk of preterm birth in these patients, and that risk increases as cervical length shortens.
And actually, Amanda Roman deserves all the credit for this humongous amount of work. Just to give credit.
Yeah, this is really a study that I've cited quite a bit in my publications. Provides good information on preterm birth risk based on cervical length measurement at the time of obtaining such measurement. So a lot of randomized trials looking at interventions less than 24 weeks. We know that preterm birth risk is increased in patients who have cervical length measurements after 24 weeks. Whether or not those interventions reduce the risk is really unknown. So that's what led us to, again, this is a proof version. Sorry, it's, this was our recent publication looking at a, systematic review and meta-analysis using individual patient level data, evaluating the utility of cerclage for patients at 24 to 26 weeks. So we want to know, is cerclage effective for these patients? 4 trials ultimately met inclusion criteria. We obtained the databases from each of those trials to make sure to only include patients that were randomized at 24 weeks or later. Important to note in this table is that, definition of cervical length shortening was different among the 4 trials, mainly just knowing TOE's trial, which was the biggest, which contributed the largest sample size, was 15 millimeters or less. Differences in cerclage technique and variation regarding tocolytic therapy and antibiotic therapy as well. So we collected just data on patients who were short cervix at 24 weeks or later. And, this was the sample size. When we compare the baseline characteristics between the 2 groups, not many of the patients had a history of preterm birth, less than, around a quarter of them. Gestational age of randomization was significantly different, but I don't think this is clinically significant because 24.8 versus 24.4 seems very similar to me, 1 or 2 days difference. And the cervical length measurement was similar between the 2 groups. just, realizing that again, it's on the shorter side, 14 and 13 millimeters. When we looked at the primary outcome, preterm birth less than 37 weeks, no significant difference, although, there was a trend towards favoring cerclage with the relative risk of 70.78, which is like a 22% decrease, which is kind of similar to what we see in the efficacy of cerclage for patients who had a short cervix less than 24 weeks. Other preterm birth outcomes were similar between the two groups. Gestational age at delivery and latency were also similar. We evaluated a number of other outcomes that we were able to in terms of neonatal outcomes as well, and there was no significant difference. And again, just keep in mind that the sample size only included 131 patients, 66 and 65 in each group, so it's quite small. We then had planned subgroup analysis based on cervical length measurement, gestational age of randomization, history of preterm birth, yes, no. Although there were no significant differences among these comparisons, what I'd like to, draw your attention to the cervical length 10 millimeters or less in history of preterm birth, we're seeing a relative risk of 0.55, which is, again, almost half the reduction in risk, although, again, not statistically significant. I mean, if you look at these percentages, it's quite, stands out at you, potentially meaning that these were the patients that might benefit the most, which we know they do in gestational ages less than 24 weeks. So, taking together the data that we published in the systematic review, we wanted to, we realized that although there was no significant difference, there was a non-significant 22% reduction in risk of preterm birth. There may be a best effect in cervical length less than 10 millimeters or history of preterm birth. Clearly, a randomized trial is needed, focusing exclusively on this patient population, just given the limitations of this analysis. So, so now just kind of open discussion and kind of some things that I'm thinking about in terms of the proposal for this randomized controlled trial. People who are eligible for inclusion will be transvaginal short cervical length less than or equal to 25 millimeters between 24 and 25 and 6 weeks versus 26 and 6, which we can talk about, a little bit after, kind of differentiating between the upper gestational age cutoff. Keep in mind that the meta-analysis was up to 26 and 6. Peri-viability, according to ACOG, is up to 25 and 6. Again, something of note to discuss. And sorry, before I guess I wanted to add this to the presentation is, going back to why do we have such limited data on patients after 24 weeks? I mean, keep in mind, people first think about viability. Is that threshold 24 weeks really related to viability? Is that like that seems rather arbitrary, right? Because if you think about it, we're performing cerclages in patients who have cervical length that's short at 22 weeks, where now ACOG supports the use of antenatal corticosteroid administration in those patients. People used to think, 24 weeks, that's when obviously the neonatal survival, it becomes more increasingly likely if you had, let's say, a complication like ruptured membranes, which is a low risk in these patients, like 1%. And the morbidity and, neonatal morbidity at 24, 25 weeks, especially, is still very high. So we shouldn't be potentially withholding a meaningful intervention in this patient population. So that was really the rationale. I forgot to kind of mention that earlier on as to why, it's reasonable to perform such a trial in these patients. So then, knowing that we want short cervix between 24 to 26, and by the way, in the majority, again, if you look at the mean gestational age, we're at 24 weeks. So that's why, again, 26 plus, are we going to be able to get patients or providers who will be willing to do a cerclage at that gestational age? So what would be the target population? Definitely short cervical length, less than with history of preterm birth. And what's clear here is that patients, we do serial cervical length surveillance 16 to 24 weeks. But if you realize in the ultrasound unit, the majority of the time they're coming at 22 to 23 weeks. So 22 and 2, 22 and 3, and we say no more cervical lengths. So we can offer them to come back in 2 weeks. Those are like probably the easiest patients to target, because those are the patients that will have a cervical length measurement at 22 plus weeks, offer them to come back in 2 weeks. I think that's like the, main population that we'll be targeting. there's short cervix with no history of preterm birth. The problem here is, again, how does that interfere with colors? When do you bring them back? Should we offer, let's say, 23 millimeters at 22 weeks who declines colors to come back in 2 weeks? And then how does that interfere with it? They ultimately get, assigned, again, something to discuss. And cervical length at 26 to 29 weeks. Cervical length 26 to 29 millimeters at the anatomy scan. Any comments on this target population? Anyone I'm missing? And whether or not including all three of these types of patients may be too heterogeneous and might impact the findings in our study.
I think for the second point, I mean, if they're not in colors, if they're in colors, I think they should only be in one trial. And I'm thinking if they decline colors, they're likely, I don't anticipate them agreeing to do a trial if they weren't if they didn't agree at the first instance. I'm not sure how you.
I also wonder, like, if they decline and they see that their cervix continues to shorten, will their mind change? I don't know, based on colors
That's
now
true.
currently. Have you found that colors patients are more likely to agree if their cervix shortens on their next ultrasound? I don't know. I haven't really encountered that.
And Dr. Goularson, these are closed short cervix, right?
Well, we haven't identified, right, if they're, so in the IPD meta-analysis, cervical dilation was not available. Whether, we can talk about whether all patients should get an exam, whether we should apply, again, the Roman criteria and recommendations are based on less than 24 weeks. So if a cervical length of 50 millimeters identified at 24 weeks, should we perform an exam, on those patients?
Sorry, go ahead.
There are, like, I think previous, and maybe you talk about, correct me if I'm wrong, I don't necessarily, if someone has, let's say, a short cervix, and then they're found to be dilated at the time of cerclage placement in a short cervix ultrasound indicated cerclage trial, it's not like they get removed from the study.
Yeah, because I think that's where the counseling with post colors would change, is like if someone had declined colors, but then is found to have an open cervix, I think those are the people who are more likely to change their mind for participation. I was just wondering if you were including that.
Yeah, I think, I'm not sure. I'm not sure what to do in that situation. Because, I don't know if we can apply, when's the right time to do a physical exam on patients with short cervix after 24 weeks. If they're not contracting or contracting, I'm not sure.
I mean, one related issue, which I think is to discuss, is that, most of the cerclage trials we have done, if not all, if you're not in the trial, we do not offer cerclage outside the trial. So for this one, I think it's easier actually than before. It's 24 and 0 and after. We don't do cerclage on anyone 24 weeks or after. So one thing to keep in mind, what you're saying is if they have a short cervix after 24 weeks, they would be offered a trial, and if they are not in the trial, then they won't get cerclage. And even if their cervix is 5 millimeters and they're open, we're not going to put a cerclage at 25 weeks. I guess it's corollary to where we were talking about, but we need to agree with that. I mean,
yeah, and I think that I'd be tempted. I would, if they have a short cervix identified on ultrasound with not ultrasound findings of cervical dilation, I would keep them and report cervical dilation at the time of cerclage, if present, yes, no, in the trial findings. That's my inclination, but I don't know if that's okay or what, if anyone, What do you guys think? So if randomized to color is not eligible, which makes sense, can offer once greater than 24 weeks decline colors.
Yeah.
Let me, yeah, that's fine. I think it's confusing right now because target population, you're talking about two different things under target population. One, you're talking about who is eligible to be randomized after 24 weeks. And one, you're talking about the population before 24 weeks who should be offered cervical length after 24 weeks. You follow what I mean?
Yes, that's true.
So there's actually two different target population to screen and target population to randomize. Why don't we do to screen first?
Okay. That's a good point.
But to screen,
Is
it's
anyone with history of preterm birth getting serial cervical length surveillance, right?
right. That's kind of what you said before. Do we want to say if somebody has a cervix of 40, and should deliver at 35 weeks, like then maybe we don't screen again. We don't have to. We can screen everybody. A lot of these women have 30, 32, 35 cervical length, and they may shorten later. It'll be okay to keep it open like this. Anyone with a history of preterm birth who is worried enough that she wants reassurance that you also have to look at that side. Any thoughts?
I think I would keep it open and just collect the data, because I think it'd be important to know if they had 40 and then 10% of them, this is patients with a history of preterm birth, and like 10 or 20% of them, it decreases way down to like 25 or something after that time. I think that'd be important to know.
Let's look back at well, I guess this doesn't tell you, let's say if you're at 22 weeks, and I think 60% or 70% of this 60% of this population had history of preterm birth. If you're 40 millimeters, I guess this is not telling you the risk of cervical length shortening after 22 weeks, but I guess the preterm birth risk is kind of,
It's still there.
I've also, I honestly, I don't even know when was the last time I saw cervical length of 40 in the ultrasound on someone's history. But yeah, I think open is fine, I guess. I like that. I mean, I guess more opportunities for potential inclusion. But I guess the question is, how does that impact our ultrasound or the ultrasound unit and the number of patients being screened if we, let's say, use like 35, which is what I think I think what Europeans or what was that pessary trial that looked at short cervix and they defined it as like 35 at SMFM in the Netherlands. Are we okay with that?
Yeah.
Okay. And then
the next bullet points, 26 to 29, we already do one follow-up before 24 weeks. You know what I mean? They already get, so maybe before that bullet point, you can we could say, so now we're talking about no prior preterm birth, right? These are no history of preterm birth. And of that population, there are I think at least two subcategories. One would be cervical length, like 30 to 35. We can discuss it. You could follow those. We don't follow those now. You know what I mean? 30 to 35. And then a follow-up. And then the 26 to 29, they get one follow-up. I guess if they still stay like that, which many do, like, you get that 27, they come back to 27 again or 28, you could probably screen them again. You follow?
Yeah.
Yeah, something like that.
So these patients, they're going to be at their anatomy. So you say like approximately 4 weeks, you offer them and then here, if it's, let's say 20, then it comes back 20 weeks, they come back at 21 weeks the same. And then, that will be and then that would be in approximately 3 weeks.
But make sure there are 24 weeks. Yeah.
Yeah, follow up. Yeah, I guess I'll just say that. Yeah. Okay.
I feel like that first bullet point under no history prior preterm birth is gonna add a significant amount of volume.
That's true.
That seems a little. I don't know, I just want to throw that out there.
Maybe if we look at the risk of going back to that paper, maybe we can make it not 35.
It's gonna be like
But we don't have, we have 30 and 35. Never mind.
Yeah.
That's probably like Katie said. I think that's going to include. I feel like that's what I always see is 30 to 35 for everybody.
Yeah. It's 34.
So how about we do this? How about just 26 or like, because 30 is not necessarily included. What about just patients 30?
Yeah.
Yeah, remember mean cervical length depends, but in our population about 34. So he's fine, he's right. I mean, that would be a humongous amount. I didn't think about that. But if we do 30, that doesn't happen.
The mean cervical length is 34.
What?
You said the mean cervical length is 34.
Yeah, I mean, in many studies in our population, even no history of birth.
Got it.
So
Yeah.
there would be too many, you're right. I didn't think about that.
Anyone else that could be? Oh, and then here's the other question about screening is patients with a prior LEAP. You know, there's some centers that do cervical length screening after 24 weeks for that. But I don't know if we should.
I think if they fit into the clinical criteria we've already outlined, then they could be included, but we're not like changing our management for those people currently.
Yeah.
And we decided on top to go to 26 weeks or 25 weeks.
We can decide that now. That wasn't one of my questions.
I mean, your data goes to 26 weeks.
Yeah, 26 and 6.
So in a way that and you know, while it doesn't happen in the States, I can tell you around the world, people place cerclages that late all the time.
Yeah.
The question is, you know, perivariability, you know, other things. But I mean, do people feel strongly about not being 26 weeks?
You know, obviously everyone has to be comfortable doing it.
All the attendings put a cerclagen
Say it
at,
again.
so will all the attendings put a cerclagen at 26 and 7?
I guess if you have an IRB, right, and it's a study pot, you know.
Yeah, but I'm saying, do all of you guys feel comfortable doing that? Not just because there's an
I
IRB.
mean, yes,
Oh yeah.
I mean,
I mean, Keely and I had.
I do.
This is so. Keely and I just did the Brittany Thompson. I know it came out 2 days later, which was really sad. But when we placed it, when we placed it with the balloon, everything, we were like, wow, like, come on, if we can do it at 23 and 6, we can do it at 24 and 6. Or
Totally.
Yeah, I mean, it was totally fine. I mean, aside from the fact that it came out 2 days later.
I hate that fact.
It was totally fine.
I agree.
Okay, we can say 26 and 6. Any other patients that are targeted to screen? I don't think so.
I don't think so.
I guess
Again.
another quick point is a corollary that I'm thinking about as I look into the slide. Are we going to screen once?
Yeah, so that's the
Mm.
if we extend to 26 and 6, because again, depending, let's say they come back. So for patients with a history, it's straightforward. If they're 22 weeks, we'll tell them to come back in 2 weeks. If they're 23 weeks, we'll tell them to come back in 2 weeks. So that's 24 and 25. But then once you're 24 weeks and we're extending the gestational age to 26 and 6, we could offer them another cervical length in 2 weeks. again, I'm not sure. I would be, maybe that could be limited to these patients. But then I don't know. That's kosher.
I mean, I like the idea of just making it every 2 weeks after 24, or making it every 2 weeks, just agreeing to have it screened.
Oh, and then if they're eligible, if they're getting at 24, they're automatically getting at 26. If they're 25, that's their last one.
Right.
Okay.
Are you going to do anything different? Let's say someone that had 3 at and was screened again at 24, it was 3, but then at 25 it's 26 to 29. Are you gonna have them come back in a week?
Damn, that's another good point. I don't know.
The only thing is that I can see the point, but the risk without a history of preterm birth, it's so much smaller when you have a short cervix than the risk if you have a history of preterm birth. So I could see the point of just ordering the history of preterm birth in 2 weeks. Like if somebody has no history of preterm birth, she's 30 millimeters, then at 24 weeks, she's 30 millimeters or 28. You're gonna follow her again. And remember, you're looking for a positive trial as well. You're studying this because you think it may work. If you put, the lower risk patients you put in, the less is going to be significant. So you actually want to have the highest risk patients possible. See what I mean?
Yeah, there is a patient that we forgot here, I guess, short cervical length. So
right, those that decline collars.
Yeah.
And the one thing with that, if they decline collars, they're probably not going to be, inclined to be randomized at a large trial, but I think it's fine. If they want to be followed, they could certainly
change of heart.
Yeah, they would change of heart, so that's good.
Or could be other one, the ones for history of preterm birth, that had a short cervix and maybe, I don't know, decline cerclage. Maybe you can follow them. Maybe they would change their mind.
Yeah.
Right, which is going to be very few, but yeah.
Okay, and then that's target population to screen versus randomize. And then that's just
Obvious, yeah.
obvious. Okay, that makes sense. Thanks for that clarification regarding screening versus randomize.
So if it's short, they're randomized.
Yeah.
So 225 or less, they just get randomized.
Yeah. And we, again, I guess to Brigida's point about, these patients wouldn't be getting a cerclage outside of a trial. Neither of these, actually. None of these. Sorry. Yeah, none of these.
Right. Are you going to talk about stratification?
What do you mean? Sorry.
Are you stratifying for any characteristic? Like looking at this slide now, I think you should probably stratify for history of preterm birth. You don't want, when you randomize, to have a lot of people with a short cervix, but no history of preterm birth on one side and everybody on the other side.
I see. I'm not. I'm not familiar with.
Yeah, when you do a randomized studies, you can stratify. People can stratify for institutions sometimes. They can stratify for, again, something like this, history of preterm birth or not. You want to make sure that the two populations are the same, right? You want to make sure that at the end, everybody's the same. The only difference is cerclage or no cerclage, so there's a difference. But if somehow when you randomize, you get people with higher risk in one group, let's say you have people in higher risk in the control group, because they have more preterm births, a shorter cervical length, etc., then cerclage is going to work, not because cerclage works, it's because the controls, were a higher risk to begin with. Make sense?
Is this, sorry if I'm confusing this, but is the way to eliminate that by only including a certain number within each population? Or no?
No, you could do like block randomization where if they have this, they get randomized, and then if they have that, they get randomized, but they're randomized separately and not together as a whole group.
That's an excellent way, but most of the time you instead stratify, which we can show you it's easy statistician, any of us can do it. And in this particular studies, you may want to stratify, and we can talk about offline, by both history of preterm birth and actually how short the cervix is. Because you don't want by chance to have the controls all being 5-10 millimeters and the other ones being longer. But in this particular trials, that would make it
But do you mean like, so I'm just understanding, let's say you have the first patient has a history of preterm birth, eligible, randomized, next patient history of preterm, like you're saying that if you patch too many patients in a row that are in a high risk group that get randomized to one side, that's what the problem is. I'm a little bit
right, correct, exactly.
Okay.
That's it. And then all of a sudden, when you do your demographic tables, when you're writing the paper, you see that again. Let's make the controls more history of preterm birth, and you're like, oh my god, they're really. The difference between the group is not only cerclage, but it's also some high risk criteria, and then you don't know anymore what the effect of cerclage over your intervention is. So you could stratify the cervical length lesser or equal than 15 or 10 to make sure that at the end the cervical lengths on both groups are the same.
Is that what you're doing for colors?
I was thinking of that while I was saying. I'm not sure, but it would have been smart if we did. I don't think so. Colors always no history of preterm birth.
Yeah.
It's a little more homogeneous than this. But I don't think we stratify the cervical.
Okay. Okay. So once they're eligible and randomized, if they were to get cerclage, the question is McDonald's being consistent. I'm not sure. I think that's what I would think is the general consensus, just based on, especially if we're making this multi-center based on provider experience. I would err on the side of including indomethacin antibiotics and deferring steroids unless much ruptured membranes during surgery. I think the question here also is, should they be sent? And I mean, I guess for everyone, I guess rule out preterm labor is important, right? And that includes an assessment of the cervix, which is, I guess, alluding to what Katie mentioned. So should all patients get a cervical assessment, like digitally?
I think so.
Okay. And then indomethacin antibiotics, just based on, here a lot, 3 of the 4 trials had that. So I think that's reasonable. And then again, the question is, steroids. I don't know if I didn't offer it to, did I offer it to Thompson? I don't remember the conversation I had. I think I just deferred it, but I remember calling Dr. Brugella about this. She was 23 and 6, but.
I'm okay with deferring.
We're all good. All right.
All good?
Yeah,
Okay. Primary outcome, preterm birth, less than 37 weeks, just like what we did for that's just like what we did for the meta-analysis. I think that's reasonable. Anyone have any objections? And then, secondary outcomes. Anything else sticks out to anyone?
sepsis, there are a few
Yeah.
more.
Yeah.
Maybe.
And then I guess, by the way, is a large portion of these patients will already be on progesterone. So just continue progesterone for those that are on it, right?
So that's actually a good.
That's a great
What,
So are you gonna
what about if
see-
they get if they're 24 weeks, now they're 20 millimeters, they were fine before,
Already started at 24.
which adjust progesterone? I'll tell you the data I know of, just to throw it out there, not an opinion. There were 2 older studies looking at 17p, because that's what we used all the time in the past. That up to 27 and 6, there was some benefit. There was case and controls, not randomized. There was some benefit. First of all, it was 17p. It wasn't as strong. It wasn't randomized. But that's like, in clinic when a resident asked me, she's 25 weeks. She's had preterm birth. Should I start progesterone? That's the only data I can quote. So they should be, first of all, if they have a history of preterm birth, they're already on progesterone.
Done. That's easy.
So start continued progesterone. The question is no history of preterm.
You have short cervix identified at 24 weeks.
Yeah, and I think, what do we do if we have a patient that comes, then they get a short cervix, they decline participation? Do we start progesterone on those patients?
For colors, if they decline colors,
No. Let's say they come back for their screening, they're in the 24 to 26 range and they have a short cervix and they decline this trial, which I don't have a name for yet, but we'll figure one out. Now it's newly diagnosed short cervix after 24 weeks. I'm looking on another screen to see. I thought that there was a randomized trial that included patients 25 and 6 for short cervix vaginal progesterone, but I don't remember.
I think when you're screening, I think they should, unless they can withdraw, but I think they understand that they'll be randomized if it's short to cerclage or no cerclage. I don't know if that's if that's part of the consent to screen, or if it should just be consented once they're short.
I'm sorry, say that again, Rodney. I didn't follow.
I was because he asked about if they decline like cerclage after that point. I feel like if they agree to be screened, it should be already agreed to be randomized to cerclage or no cerclage if it's short later on.
So this actually opens another big deal, which always comes up with the cerclage style. Do you consent them at 22 weeks or 20 weeks for the cervical length and cerclage? Kind of what Rodney's saying.
Yeah.
When to randomize.
Yeah.
Or do you consent them, 24, 25 weeks when they're short? And there are pros and cons to each of those. What were your thoughts, Moti, in terms of when would you like to randomize?
I think, again, correct me if I'm wrong, staying consistent with what previous trials had done is when the short cervix is detected.
Yeah, but some people will make the argument that, the cervical length at 24 weeks is experimental, so to speak, we're not doing it now. And therefore the patient is kind of entering research to begin with. And some people may also say it will help your recruitment because the consent already says, you will be randomized, if your cervix is 25 or less, which, she can still decline, and some will. But in a way, that's when your study is starting.
Yeah, I'm not sure what's best there.
Gala just had to step out for 1 second. That was the call.
Yeah. So I guess just I'll say that.
I guess the patients that agree to screen, I feel like they would already, maybe the situation wouldn't happen too often because they know, like, that's one of the appeals of being screened and to do something about it.
Yeah, I'm not sure. I guess we can think about that. I did a power analysis, which was what
Did you solve? Sorry, I stepped out. Did you solve the progesterone issue? Did you or not?
No.
Okay. One thought that I had, Moti, and again, you eventually can decide. We don't have to decide everything now, but one thing is, that's based on the meta-analysis of Romero, so women without a history of preterm birth, they have a short cervix, the randomized studies show vaginal progesterone is beneficial. Quite a few of those randomized studies went to at least 25 weeks. And I think actually that's in his conclusion. I know that's not in the guidelines. So there is some data, there are at least some patients included at 24 weeks and 25 weeks. So you can make an argument for progesterone and offering on both sides.
Yeah, that's what I thought was the. Oh, 1 second, sorry. Is that okay?
Yeah.
Okay, thanks.
And maybe this will also make it more, clinically relevant and valuable to patients, meaning, you're getting an extra screen, you have to come in the waiting room and this and that, but at least if your cervix is short, not only you have a 50% chance of cerclage, you also have a 100% chance of progesterone. You were doing something for finding it. Just.
I think it's low risk potential, and then there's the potential for benefit. I'm trying to find the exact trial that included patients up to 26. I just can't find it, but because that was always a discussion. Remember, my first research question before cerclage was utility of progesterone after 24 weeks. But now that patients with a history of preterm birth are going to be on vaginal progesterone anyway, we just jumped to cerclage. But yeah, we can that. I think it's reasonable to offer it to patients if they have short cervix after 24 weeks, and for them to continue it if they get randomized to cerclage.
That's good.
Power analysis based on a preterm birth rate of 50%. If we're including mostly patients with a history of preterm birth, would require 148 patients in each group. Obviously, that's a large number. Hope would be to make this multi-center. And this was the analysis that we use, assuming 80% power with an alpha of 0.05.
Corollary to this, which we haven't discussed, Moti, is it'd be good for you to get an idea of how many how long it would take you. Now that you know who you're going to screen, let's say 10% of our patients have as a preterm birth. 40% will have a short cervix before 24 weeks, but So, kind of, we can look at, and we can do it together, how many patients will be offered. We probably need to assume that maybe 50–60% will agree to come back, and from that you kind of get an idea of, is this a 1 year, 5 year, 10 year? If people do kind of a graph of recruitment progress.
Yeah. I trial. Oh yeah, I guess duration, time. How long? Okay. And then just some questions. So should we have a dating ultrasound gestational age cutoff? First trimester versus less than 20 weeks? I think Amanda mentioned in her twins she did 20 weeks, but I'm not sure.
20 weeks.
20?
Yeah, I just want to finish before 12, trying to get
it. So is this, I guess we're going to include this to be answered. This one, cervical length cutoff, again, I think just, again, whether or not it's 25 millimeters, because, for patients, let's say without history, but I think we all agree that 25 millimeters is fine just to maintain consistency.
Yeah.
So I don't know why I wrote that. Additional cervical length. Oh yeah. So what happens to patients if you get the 24-week scan and then they get, so I guess we'll do Q2 weeks, and those are the history of preterm birth. And then those without a history, that's their last ultrasound. Is that what we're saying?
Yeah.
Okay. And then, impact on ultrasound volume was my thing, how that's an ultrasound unit.
And that's why it'd be good to kind of estimate how many patients, from that screening criteria, you'll be able to estimate that, and then you can talk with
Okay. And then we said we'll do a pelvic exam on all patients. Antibiotics, I think we agree, and cerclage technique, I guess I can remove these, but essentially we'll do McDonald and yes to antibiotics, and we'll just treat as if like 1 gram Ancef.
And we're not the type of suture.
Oh, I think that based on the C-Stitch trial, we can say C-Stitch 2 trial, we can say either or, no? Or is that too heterogeneous?
I think it was just
Yeah. Pardon me?
I think either or is fine.
Yeah. That's all. I mean, anyone else have any questions? Thanks for cooperating. It's really my first time even kind of delve into this type of stuff. So I may have missed some things. I appreciate everyone's feedback.
This is really a huge change in mindset, even in, for I think for everyone, it's I think it's a really big deal, and looking forward to it. Don't forget, if you to register it sooner rather than later on clinical trials, and this is great.
But can you register without having included other centers yet?
Yeah, you can always change it. The registration, most of it is so that people know your primary outcome, your main secondary outcomes, and things like that. And you shouldn't register it today, but you can. Nobody's going to fault you for including or excluding more trials. It's the protocol. It's your sample size, primary outcome, inclusion, exclusion criteria. That's that kind of set before your first patient is randomized. Great.
Great, thank you everyone. I really appreciate it.
What's the name of the trial?
Oh, I have that. That's I welcome all all suggestions.
I guess we need a group share for that one.
She's unfortunately not here. Maybe I'll ask, but
late cyclage.
I think something like 24 plus. No, I don't know. Something 24. I don't know. I'm thinking like
Very viable for class.
the viable cerclage study.
Oh, no, I have, that's a good one. I have why don't we call it, since it's the second trimester? So we could call it middle of trimester initiative. What do you think?
What's the abbreviation though?
Middle of trimester initiative.
Oh, Moti.
But it's the second trimester, that's the way, and it's a new thing, initiative.
Let's do it.
Or intervention.
Intervention.
Middle of
Intervention.
trimester intervention.
Intervention.
Better.
The Moti
Cerclage,
trial.
Yes, that's amazing.
That's amazing.
I mean, it has to be at that, so.
It has to be that.
That's what we thought.
Yeah.
Middle of trimester.
Intervention.
I'm writing this.
Yeah. I tried Goolerson, it's just too long.
You need to do a Twitter poll for the name. Things, and then we'll let the public.
That's hilarious.
Oh, that's amazing.
That made me laugh. I appreciate that.
I love, oh my God, that's just so amazing.
Well done, well done.
All right, thanks everyone.
Thanks, everyone. I think we're good.
All right,
Have a great day. Happy holidays.
take care.
It's so funny.